lessons and best practices from the past 10 years. And we're also able to share sustainability measures for the adoption of some of the lessons that have been learned from this entire program. I'm sure all of us are aware of the WHO report, I think, that was released this February about 2020, where 1 in every 2 minutes, we have a woman dying from preventable causes related to pregnancy and childbirth. So I think this particular event comes at a very timely time for us to be able to discuss and know how to reduce this, because a majority of these deaths happen in low and middle income countries. That's 95% of them. Kenya obviously is part of this group. And, you know, most importantly, it's been shown that skilled care saves lives. And I think the program that has been happening will be able to see how those lessons and that program is able to save lives. So we are very privileged to be here today, and I want to welcome you. My name is Dr. Mercy Korir. I'm your MC for the day, and we look forward to a very fruitful event. So before we officially start, I'd like us to commit the event and the 2-day conference to the Lord in prayer. We'll have 2 prayers, a Christian prayer and a Muslim prayer. So if could all stand so that we have a prayer. The first one will be by Karen Aura from the Ministry of Health, and then Aden Hussein from Garissa County, the Director of Health. So Karen.
All right, good morning.
Good morning.
Let's bow down and pray. Father, in the mighty name of Jesus, we thank you for this beautiful day that you brought forth to us. We rejoice and we are glad in it, O Jehovah. We thank you for the sufficient grace, O my Father, that you've granted us this day. We thank you even for the mercy that you renew in our lives every morning, O my Father. As we are gathered here today, O my Father, you say that where 2 or 3 are gathered, you are in their midst. We appreciate your presence in this place, O my Father. As we deliberate on all the liberation of this day and tomorrow, Jehovah, may you be with us, O my Father. Empower us with divine wisdom, divine knowledge, so that whatever we discuss, oh my Father, may it come from above, oh my Father. We lift your name up, oh my Father, because there is none like you. We thank you and we glorify your holy name. In the mighty name of Jesus, I pray and give thanks.
Amen. So the Muslim prayer.
Bismillahirrahmanirrahim. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب ربنا هب لنا من أزواجنا وذرية أعيننا واجعلنا للمتقين إماما آمين.
Amen. Thank you very much. You can all take your seats. We'll start the program by listening to different welcoming remarks from the partners that have been instrumental in this program. But for those of us who are on social media, I hope everyone has a gadget. You can interact with us on Twitter. The hashtag is Maternal Health or MNHQOC, LSTM Impact, or SDG3. The hashtags on social media, Maternal Health, MNHQOC, LSTM Impact, and SDG3. So without further ado, let me welcome the LSTM Country Director, Lucy Nyaga, to come and give her welcome remarks, and then we'll continue hearing from the rest of the participants, from the rest of the partners in this program. Karibu sana, Lucy.
Thank you, Mercy. His Excellency, the Governor of Vihiga, Dr. Wilbur Otichilo, in absentia, the representative to the DG's office, Dr. Andrew Mulwa, the Director, Preventive and Promotive Health. In absentia also, but soon to be here, the Head of Department of Family Health, Dr. Bashir, our donor from the British High Commission, Head of Department, Deputy Head of Department of Development, Richard, Professor Charles Ame, the head of International Public Health from Liverpool School of Tropical Medicine, representative from the UN, Dr. Chris Oyeyipo, excuse me if I mispronounced that, our partners from around the country who have come to join us today, our colleagues from the counties, colleagues from LSTM, good morning. It's a great pleasure to be here this morning. I'm really happy to see you all here. And you know, from where I stand, all the faces look bright. And I'm really privileged to be here to really welcome these bright and expectant faces. And without saying too much, mine will be very simple. To just welcome you to this event. As we know, and we've heard and we've seen from the communications that we are here, we are coming today so that we can have lessons learned and best practices from the work that in leadership of the Ministry of Health, working closely with the Department of Division of Family Health and Department of Reproductive Health, we have come a long way in implementing the Reducing Maternal and Newborn Health program. This program has run actually not for 10 years, but for 14 years. We've been here 14 years, since 2009. And I think that's a long period that we have worked, we have interacted with, I think almost everybody in this room must have interacted with that program. And having implemented this program for such a long time, this program is coming to an end in March 2013. And as LSTM, together with the ministry and together with the counties that we work with, we decided we are not just slightly sliding out, you know, of the scene, in quotes, for the time being. We have to share what we have learned, what we have done, where we have failed, so that the work that we've done in the last 14 years contributes to what is ongoing. Because as we've had, as we have had, we still have a battle to fight in terms of reducing preventable maternal and newborn health. And therefore, having 14 years of experience and just slightly, you know, slowly slipping away was not an option for us. It was not an option for our donor, you know, the UK Aid. And in fact, this was an insistence that this event has to happen, I think, from all these key stakeholders, from the UK Aid, from the Ministry of Health, and from our counties. And I stand here to really thank you all for making this happen this morning. It's because of the concerted effort. We all know what it takes to really convene this large group here. And therefore, I really hope that this occasion, even as I welcome you, remember that this occasion we've made it possible so that we can move our lessons forward, so that we can share what we have done. For our partners that are not part of the, what I would call the core team that has been implementing this program, we really hope that you take the baton and take it forward and run with it, so that what we continue hearing about deaths of a mother, deaths of our babies can stop. So because this is a 2-day packed event, you can imagine, you know, trying to capture 14 years of work in 48 hours. It's not even 48, it's 8 plus 8. We work for 8 hours a day. In 16 hours, it's quite a task. But I'm sure with the preparations that we've all had, we are up to the task. We will be able to pass the baton for those who are still working in this field, and we'll be able as well to have opportunities to interact. And also, because as LSTM, we are not exiting out of maternal health, just in the context of this UK Aid-funded program, we will be able to also learn from yourselves. So to keep this short, because I'm not coming to give any much of a speech, I'm just coming to make you feel at home, feel welcome, and ask you to kindly contribute with all you can. We all came from our mothers. We all survived. That's why we are here. And by the fact that we are here, we have something that we can give so that we prevent mothers and children from dying from things that can be prevented. And when I look in this room, we have all the expertise that we need to do that. We have all the instruments. We have all the networks that we need to do that. So welcome and engage, knowing that you're here because you have a role to play. You're here, and because I know we have prayed, you're here because it's not by chance. It's a God-given chance. Do not waste it. With those few remarks, welcome and feel at home. Let's continue to interact. Thank you.
Thank you very much, Lucy. Next, I'd like to welcome Richard Albach, the Deputy Development Director from the British High Commission, to give us his welcome remarks.
Thank you. Thank you, Mercy. Good morning.
Good morning.
As Lucy has said, I see lots of bright faces. I'm honored to be speaking second on this morning, and recognize Lucy's warm welcome to you all, and to say on behalf of the British government how honored I am to be here, and honored to have been part of the partnership that we've had over the last 4 years, 6 years, 13 years, 14 years that you've mentioned. Anyway, Governor Otichilo, representatives of the Kenyan government, representatives of Liverpool School, Tropical Medicine, representatives from counties, from partners, from the UK government as well. It is a pleasure to be here. All protocols observed. Forgive me for not going around and mentioning all the names. Lucy's done a great job of recognizing you all already. So the UK has a long and successful partnership with the government of Kenya in the health sector, and we're very proud of what we have done together, both within this program, but more broadly. Over 20 years of investment, many different programs, but always with a focus on maternal, child, and newborn health. Ending preventable deaths, I'm told, is a core priority for the UK government, and we've committed to zero maternal and child deaths by 2030, and that's the same commitment that has been made here in Kenya. However, as I think Lucy has mentioned, we know that is far from the reality. And I think in 2017 it was 8,000 mothers who died at childbirth, and the challenge is how can we work together to bring that down? And I don't know the answer. That's why I'm here. I've come to learn from the work that you've all been doing to try and achieve that, and to make a difference to the lives of mothers and babies. So Lucy mentioned the issue of skilled birth attendants, and I'm conscious that the latest health survey data suggests that there's an amazing inequality in Kenya. Amazing, not in a good way. The challenges that are faced in communities in Mandera, Wajir, Samburu, Turkana, the distances that are traveled, the availability of healthcare is really difficult, and it makes giving birth with a skilled birth attendant very difficult. And whilst there has been progress, there's still much to be done. I'm pleased to hear that places like Vihiga, 95% of women give birth with skilled birth attendants. I mean, that's fantastic, Governor. And I think the question is, how can we learn from your experience and elsewhere to really make a difference elsewhere? So as I said, mine is really just to welcome and to say thank you all for coming. Thank you all for your work over the last 4 years, 6 years, 13 years, and even longer. And to recognize that there is much still to be done. But we are on this journey together. The UK support for Kenya, as I said, is long-standing and will continue. And with that, let me say thank you and pass back to Mercy. Thank you all.
Thank you very much. Thank you very much, Richard, for your remarks. Next, I'd like to welcome remarks from the Council of Governors, Dr. Emmanuel Wamalwa. Let's welcome him with a round of applause as he makes it to give us his remarks. Karibu sana, Daktari.
Thank you very much, Mercy. Your Excellency, Governor Otichilo, Governor of Vihiga County, and also a member of the COG Health Committee, Government of Kenya officials, representatives from FCDO and other development partners in the House, as well as I see a number of civil society actors. All protocols observed. Good morning. I stand here to read remarks on behalf of the COG from the CEO of the Council, and on this very important occasion. And first, before I say anything, let me start by thanking the UK aid and the British people for the long-standing and solid partnership you have granted Kenya over the years. We've really enjoyed the partnership with the UK government. Your partnership and support has helped Kenya to save lives and improve the quality of life for millions of citizens. Let me also take this opportunity to thank you all gathered here for the purposes of improving the lives of Kenyans. In this regard, allow me to take this as the opportunity to, on behalf of the Council of Governors, on behalf of county governments, and on my own behalf, to thank you for both your partnership and for convening this forum. It's always an honor to join a meeting like this that is focused on learning. If well-utilized forums like this can go a long way in improving the quality of lives in populations. Learning forums place knowledge, evidence, and practical strategies right at our tables. They give us the opportunity to listen to one another, to discuss, learn, innovate, and share experiences on how to improve health outcomes. As you know, improving sexual, reproductive, maternal, newborn, and child health remains a priority of the government of Kenya, and that's both at national and county level. Ladies and gentlemen, this year we celebrate 10 years of devolution in Kenya. Today, county governments continue to contribute tremendously to the health and development outcomes of the Kenyan people. The devolved health system has provided a unique window of opportunity for Kenya to address long-standing inequities, responsiveness, and inefficiencies that had for a long time plagued our health system. It is key to note that since the onset of devolution, there has been notable improvements across all pillars of the health system. We now have a political and leadership system that is more aware of the priorities of health and development. We have rapidly expanded our health infrastructure, human resources, and increased investments in other critical components of health. If you look around, ladies and gentlemen, across counties, you'll agree with me that there have been significant investments in health across all pillars in the past 10 years. Our human resources for health, the most important health resource, has become more accountable to citizens, but also freer to raise issues and concern in their practice. Devolution, ladies and gentlemen, can provide that much needed anchor for new innovative models of healthcare, including those that optimize the impacts in RMN-CAH. Of course, we do have challenges. But even as we look at addressing these challenges, it is important to take note of the strong points that can help us optimize our results. Ladies and gentlemen, as I finalize, let me just highlight that it's not possible for me to live here without talking about the drought that continues to occur within this part of the world and the Horn of Africa. We know that drought causes devastating effects on health outcomes, including on reproductive, maternal, newborn, and child health. Most of the time, children and women suffer the most, some paying with their own lives. This year, and most of last year, arid and semi-arid counties are once more facing drought. As the national government, county governments, and humanitarian actors continue to respond to disaster, it is necessary for actors in this room to refocus their help to families, communities, and government to ensure that these better navigate this difficult period without losing the gains that we have made in maternal and child health. It is indeed our hope that we will see more of you working side by side with us in these affected counties. Finally, ladies and gentlemen, the Council of Governors encourages your continued contribution to health and RMN-CAH as we journey towards universal health coverage. County governments remain fully committed to fulfilling the requirements provided by the Constitution of Kenya that guarantee all citizens the right to affordable and accessible quality healthcare. This right includes reproductive, maternal, newborn, and child health rights, child health services. On behalf of the Council, therefore, county governments, and my own behalf, I thank you once more and reiterate our full commitment to work with all of you in improving health for the people of Kenya. Thank you.
Thank you very much, Daktari, for your remarks. Thank you very much. It's good to get the confirmation that as county governments, they are supporting all the programs that are being implemented, especially towards saving the lives of our mothers and young children. Next, I'd like to welcome remarks from the Ministry of Health. We are still waiting for Dr. Bashir or Dr. Andrew Mulwa, but these remarks will be made by Karen Aura. Just briefly, let's welcome Karen. Karibu sana.
His Excellency, Vihiga Governor, Mr. Otichilo, representatives from British High Commission, all other players and partners in this meeting, good morning. Dr. Mulwa and Dr. Bashir are on their way coming, so I will not do remarks on their behalf because protocol is observed. So for now, I welcome you as the Minister of Health. Please feel appreciated. We love you, and we are happy to collaborate with you as a ministry, and our collaboration, you can see, imezaa matunda. For those who understand English. If you do not understand English, our collaboration has made this country proud of reproductive health as a program. So thank you very much for coming. We appreciate your presence today. Thank you.
Thank you very much, Karen, for the welcome note. Then on our welcoming remarks, the final part of the program, I'd like to welcome Professor Charles Ame to give us an overview of the MNH program, the input, the activities that have been there, the outputs, and the impact. Professor Ame is from the Liverpool School of Tropical Medicine. Karibu sana.
Great to see Governor of Vihiga here. He hosted us, and I really enjoyed his passion for improving the lives of women and children. And I think his presence here is a testament to that sort of passion and vision. So I warmly welcome him, and also I thank our donors from FCDO, the government of the United Kingdom, for all the support over the years. Martin, is this thing working now? Yes. Fine. So I'm going to be just giving an overview of the program. I'm based at the Liverpool School of Tropical Medicine, and I head the International Public Health Department. My background is in obstetrics and gynecology, and in the last 15 years I've done a lot of work internationally in the microphone has disappeared. Right. Hello, can you hear me? Hello? Yeah. So over the next few minutes, I'm just going to talk about the burden of maternal deaths. We all must have heard in the news, or some of us have looked at the latest report that has come from the WHO, painting a very grim picture of the progress towards improving maternal health and the lack of progress over the last 5 years, the first 5 years of the SDGs. Whereas there are many reasons for that, we can discuss the complexity of improving maternal health. I'm going to speak a bit about our landmark program, which was funded by the UK government, multi-country, over several years. And I'm going to discuss some of the impact and the inroads we made in that program, and how we moved into expanding on that work in Kenya. Then I'm going to talk about this event and the series that we've been doing over the last 1 year, in the last year of our program in Kenya. And then, we're going to look at, the program for the next 2 days. Martin, I think it stopped working. Huh? Just press next slide for me. Don't worry. Let's drop this thing. It's not working. Next slide. Yes. So we still have nearly 300,000 women dying globally in 2020. And, the latest estimates from the WHO are quite interesting. It tells us two things. At the country level, I know we're going to talk about, the data from Kenya, demographic and health surveys, census on maternal deaths. Those figures look different from what the WHO has presented. But I mean, just to cut all the argument short, whether you look at the Kenyan figures or the WHO figures, the trends are the same. There's almost no improvement over the last 5 years, over the last 10 years. It tells us that the problem is complex, but there are huge opportunities. There are many things that we can learn. Now, the key lesson from the measurement disparities that we see is that as a country, I think what we need to aim for is the gold standard in terms of measuring maternal deaths, which is just having a robust vital registration system. So if every birth and every death is recorded, then we will not have those controversies. We don't have to depend on population-based surveys, sample size issues, retrospective recollection of maternal deaths, and it's not accurate. But that is besides the point. The point is, any way you want to measure it, we have not made progress. And, something a colleague from FCDO talked about, one of the big problems we have is the huge disparities, when you look at the population, the subpopulations, if you look at where most of these deaths are happening. And from the Kenya data, we know that, there are just a handful of counties that probably contribute to up to 95% of maternal deaths. And there are different approaches. You can decide to focus all your efforts in those areas and rapidly bring down the numbers, within a short time, which is one way of doing it. But, I mean, we need to really understand what this tells us. But let's go back and let's look at some of the very good research that has been done around maternal mortality. Now, you can make significant improvement in health systems, improve access to evidence-based care for women and newborns to reduce maternal deaths. But you get to a certain point, between 300 and 500 maternal deaths per 100,000 live births, where without improving the quality of care provided, you're not going to make much difference in further lowering the rate of maternal deaths. Now, so what does this mean for us? So if you look at one of the key indicators globally for monitoring the improvement in maternal health, we look at the proportion of births attended by skilled health personnel. So government has done a lot. So many medical schools, nursing schools, healthcare personnel trained and deployed, access is improved, but we're still not reducing maternal mortality. So maybe it's time we need to pay attention to quality. And when we start paying attention to quality, we need to learn from everything we do, and those things that are working, we need to take them to scale. I think that is the main thing, the main message that I would like to, next slide please, I would like to deliver. So the Making It Happen program, this was quite a large program run between 2009 to 2016, multi-country, 3 Asian countries and 5 African countries. So we had Bangladesh, India, Kenya, Sierra Leone, Zimbabwe, Malawi, Pakistan, Ghana, Nigeria, Tanzania, and India. And we worked with multiple stakeholders to adapt specific interventions which were aimed at improving the quality of skilled health providers. So we had the healthcare providers in numbers, but there was something about their ability to respond to obstetric emergencies. So when a woman comes in that needs emergency care, so look, most pregnancy and childbirth will go on normally, they will give birth, there will be no problems. But for 15 out of every 100 women who is pregnant, she will require what we call emergency obstetric care. So you need a healthcare provider who can recognize us as a problem, who can start action promptly, and who is working in an enabling environment, so they have all the tools to use. If a woman needs blood because she has bled so much, there's so much amount of IV fluids you can give. IV fluid does not carry oxygen, does it? Blood carries oxygen, so you need to give blood. If she needs surgery, you need an operation theater that works. You need somebody that knows what to do, otherwise you cannot save that life. So people need to work within that environment. But our focus here was to try and improve the training of these healthcare workers, but we focused on those ones who had already graduated. So we developed, evidence-based training packages, worked with national colleagues, to adapt this in each of these countries, and we scaled it up. Next slide, please. So we used this sort of logic model, looking at ways whereby these training packages in each one of these countries are not dependent on Liverpool, as it were. So we worked with the Ministry of Health to put in the infrastructure in place to continue such training at the in-service level. So things like shorter training. So when I first came to Kenya, 2008, the training package for emergency obstetric care was 2 weeks. And this was similar in most parts of Africa. Now, so just imagine this. I'll tell you this story, and this has happened. So you have a healthcare worker goes for a training for 2 weeks. What happens when they're away from that healthcare facility? And, the places in Africa have gone to primary healthcare, where you have fewer healthcare workers, 2, 3 midwives. You reach there on that day, the door is shut, and there's a mobile number written in chalk on the door. Call me, gone for training. So what we have not counted is the number of women that died when people have gone for training. Training is good, but it needs to be done efficiently. So we came up with a system where you have shorter trainings, hands-on training, more facility-based, use a lot of mannequins and all of that. So a huge infrastructure. I mean, one full set of training equipment costs a lot of money, to bring into the country. And over that period, we deployed a lot of these equipments to many facilities around the country, all of these countries where we work, put the personnel in place with the right skills to be able to train and teach their colleagues and mentor them. But next slide, please. But we did something quite interesting as well. We tried to measure our experiences and we tried to measure the impact. And, in my previous slide, I mean, these slides are available. You can look at some of the academic publications. There are links to independent reviews of the program where you can appreciate these numbers. But, I just read out, some of the key outputs. We were supporting almost 1,000 facilities in all of these countries, and we trained nearly 19,000 healthcare workers, and we were able to demonstrate that they improved their knowledge and skills significantly. And in terms of that infrastructure to continue doing this, nearly 1,700 master trainers, skills labs, and 274 skills training rooms were set up in all of these places. But quite interestingly, this sort of way of thinking, knowing that we can have these can-do attitudes to change the way we practice, to improve the outcomes in terms of the quality of care that we produce. This was quite catalytic, in that you had healthcare workers now advocating with management for more equipment, to have things in place, more allocation of funds, to run CPD programs within their facilities. And you can imagine some of the discussions that we had. Well, we did not have an update this weekend because there was no money for tea and mandazi. I mean, seriously. On the grand scheme of things, somebody can get upset and pay for that, isn't it? But these are the kind of discussions that we used to have. And I used to challenge them to say, you know what, I'm sure if you talk to the MedSoup, he can organize this. This is not a big deal. So long as we all value what impact this can have. So those kind of things, getting the equipment in place. When I came into Kenya, the assisted vaginal delivery Kiwi cup, for those of you who are medical, a small device used to assist women who have delayed second stage of labor, was not on KEMSA supply list. It was through this training package, teaching people how to do it, and we introduced that equipment, and it is now on that supply list, and it's been procured at county level everywhere, and people are doing it. So giving a real option in terms of delivery, other than cesarean section. Cesarean sections it's a dangerous procedure. It's not a walk in the park. And it's not for the faint-hearted. So, and we'll talk about this, the impact of cesarean section and the alternatives, just to improve safety and quality. So these are some of the things that this program did. In terms of when you look at healthcare facility level, almost 70% of the healthcare facilities, we increase their capacity to provide, those emergency obstetric care signal functions. And then looking at the bigger picture in terms of impact, nearly 7,000 stillbirths were avoided. 1,400 mothers' lives were saved. A total of 13,000 lives were saved in that program. And we worked out the cost per mother and newborn life saved in each one of those settings. Next slide, please. So specifically in Kenya, by 2012, we had worked with the Ministry of Health to completely repackage the National Emergency Obstetric Care Training package. So reducing it from 2 weeks to less than a week, and now using evidence-based training techniques. We had embedded and provided evidence that facility-based mentorship was quite effective. And when I first introduced the concept of facility-based mentorship, I remember I was in the meeting in Kenya here with stakeholders. So in terms of lessons learned, so we've introduced what we call the blended learning approach, something we learned from the challenge provided through COVID-19. This further helped us to reduce the length of the training package from 5 days to 1.5 days, and putting a lot of responsibility on healthcare workers to do self-directed learning. So a lot of those materials have been put on a portal accredited by the medical and dental. Can take a lot of the theoretical component of these trainings, and then they spend a shorter time, meaning that they're away from the facility for a much shorter time, intensive hands-on training. We've also scaled up those skills labs and mannequins. Now, what I would need to say here is that we've made significant investment in terms of these mannequins and skills. You know, if they are well used, I mean, for anything you buy shoes, you run every day, you walk every day. For some, it will start wearing off, isn't it? It needs to be replaced. Somebody needs to replace it. We need to make deliberate plans. How do we replace this equipment? We have a mapping of where all this equipment are around this country, training institutions, with county governments and reproductive health teams that they use for mentoring and all of that. But what I have seen is that, you know, they're getting worn out. They need to be replaced. Somebody else, some other program, the government, somebody needs to replace those things. Otherwise, all these gains, you know, will go back to square one. Chalk and blackboard, you know, all those things will become, you know, you cannot use them. So this is something that we need to really think about. During our program, we're able to increase the number of, the amount of funding from counties to run sort of in-service training programs, and this was really fantastic. We achieved, you know, 80% of this, where county governments have in their annual work plan emergency obstetric care training, and they're funding it. So this is a huge achievement. So lots of facility-based training, and I'll just say a word there about the issue of DSA. So, I mean, so we have these regulations, what to pay people when they go for training and all of that, which is great. But it is so expensive and really relies on donors. It is difficult to sustain. It is a threat to, you know, most of, you know, all these training interventions. I don't have a solution to that, but it's something to be aware of. We struggled with it. And, you know, at times different partners pay differently. So people can decide which training they want to go to. If it's more, you know, if it pays better, you know, we go. So, I mean, it's just ridiculous. But, you know, this is an issue which needs to be looked into. Then there's the issue of industrial action. So, of course, we know the industrial action, it affects the implementation of the program. But most importantly, it will now even further increase the risk of women not having good quality care. The MPDSR work stream, you know, in a nutshell, you know, was about strengthening those systems at national, county, and facility levels to use that methodology to improve the quality of care. We will talk more about that later on. There were several outputs from this, you know, producing several documents. Kenya is only one of 3 countries in Africa that does confidential inquiry into maternal deaths, and there's been a lot of learnings from what you've achieved here in Kenya. So congratulations to everyone and the Ministry of Health. Next slide. So in terms of the lessons learned from MPDSR, so we feel that there's still a lot of way to go in terms of the response, and you know, everybody has a responsibility in this. The quality of the data is quite important. There are issues with quality of data from facility level which needs to be improved. We need to continue putting in, you know, that support from the county level and also from the national level to sustain a lot of the things that have been put in place, and to really link those actions that come from maternal death reviews into tangible, measurable actions, which we need to track to see that we are making a difference. Next slide, please. So the objective, like Lucia said, the objective of the knowledge management and learning event, so we instituted this in the last year of our program. So since last year, we started this event, March last year. And the plan was that we want to share what we have learned over the years, what works, what doesn't work, with other partners in this space. We wanted to share with the counties. And, you know, we want those who are implementing to, you know, improve the quality of what they're implementing. And we did not limit the invitation to these meetings just to our target counties. We invited neighboring counties and all other counties to come and listen to what was happening and, get ideas from there. So, and also we developed with our key stakeholders sustainability plans, which we have agreed with the Ministry of Health. Next slide, please. So over 3 events, in each one of our counties and our final event now, we're trying to achieve all of this. And all the stakeholders here represented, we thank you for coming. We will hear over the next slide, please. Over the next 2 days, we're going to cover quite a lot, looking into details. Just some pictures from some of the previous events. Next, please. So, a lot said already. So you've all been given a booklet, event booklet. Now this event booklet contains lots of information about, it has a program for what's going to happen the next 2 days. Day 1, we're going to have 2 panels. We're going to have awards and recognition. We're going to talk more about this. We feel that, just simply recognizing people for their efforts, is a huge incentive to improving quality of care. Recognition may not be monetary, but, it helps their careers, it spurs them on, and they continue doing things. So this is something we've tried and we see it work. So we're going to continue in that, recognizing some of our colleagues who've done, and institutions who've really done outstanding work. There's going to be dinner in the evening, and then we're going to launch our podcast series. So, a series of audio podcast discussions, with key stakeholders on the impact of the program in Kenya to date. Day 2, we're going to focus on a lot of the implementation science outputs, working in 3 parallel sessions. So when you come in tomorrow, you will be, there will be, if you come early, you can self-allocate. After a certain point, you will be allocated, to fill in the gap elsewhere. And then tomorrow, we're going to talk about sustainability plans, and then we also have a panel to wrap up. Next slide, please. So I'm quite proud to have led, an internationally recognized exceptional team to implement maternal health programs in several countries, but especially in Kenya. A country I refer, I think it's my second home. I come to Kenya almost every month. The only thing I've not got used to is eating ugali, but every other thing is fine. Every other thing is fine. So thanks to all our partners, thanks to my amazing team. Next slide, please. Thanks, next slide, please. And thanks to an amazing institution. So the Liverpool School of Tropical Medicine, this year we celebrate 125 years. Our 125 years anniversary. Kenya has been selected as one of our global hubs. There's several activities planned in Kenya. You'll be pleased to note that we have almost 500 alumni from LSTM in Kenya, the largest in Africa. And so we want to continue investing in Kenya, not just in health programs, but also it's about education and research to improve the quality of life and to improve the life of the citizens of Kenya. So I say welcome everyone. Let's keep talking, let's interact. And MC, I apologize, I definitely went over time. Sure.
Thank you. Thank you very much, Professor Ame. Thank you. Let's give him a warmer round of applause, please. Thank you very much. I think that's a good overview of what the program is. And also, he's gone through to give us what we expect for the next 2 days. I'm looking forward to the awards because, as you say, it may not be monetary, but it's always good to feel appreciated for the work done. So next, we'll go to the panel discussion. We'll make it very brief and short so that we just have an overview of the key lessons and what the next steps are from the MNH program in order to meet the national MNH and SDG targets, and also to look at the opportunities to utilize and scale up evidence generated and the lessons learned from these lessons. So I'll call in our panelists for this conversation. you'll please come to the podium and take a seat. Our first panelist is from the FCDO. She's a senior public health specialist with over 20 years working in sub-Saharan Africa. I can see her smiling. And currently the FCDO health advisor. And this is one of our flagship programs, Ms. Akacho Ekirapa. Let's give her a warm welcome. Please take a seat. Next, from the Ministry of Health, Dr. Bashir Isaac, the head of Department of Family Health at the Ministry of Health. Karibu sana daktari. Let's welcome him. Then the next person, she has been here before to welcome us, with 20 years of experience in reproductive, maternal, child, and adolescent health. She's provided leadership in this FCDO program for the last 4 years, providing both technical and management leadership. So Lucy Nyaga, karibu sana. Let's welcome her. And then from the university, I was telling Lucy and Ryle the other day that when EMONC was being introduced, I was of being out of university. So I never got the chance to get the pre-service training. And then I moved out of practice, so I never got the chance of in-service training. He taught me through University Obs-Gynae. She's currently the chair and the associate professor, Department of Obstetrics and Gynecology at the University of Nairobi, and her subspecialty is gynecological oncology, with over 30 years of teaching experience. She's the department coordinator for the EMONC training. This is Professor Eunice Cheserem. Karibu sana, Professor. Let's give her a round of applause. Then I'd like to also welcome from the county of Vihiga. He has a PhD in natural resources, mapping, and assessment from France. Politics, he was the DG for Regional Center for Mapping of Resources Development for Eastern and Southern Africa. Previously, the Member of Parliament for Emuhaya constituency, and now the for Chair of Environment and Climate at the Council of Governors, His Excellency Governor Dr. Wilbur Otichilo. Karibu sana, Governor. Then last but not least, welcoming him back on stage, Professor Ame. He had introduced himself, but I'll make a brief. My notes have failed me. Professor Ame is the head of department at the International Public Health at LSTM, Professor of Health. He's also an OBGY and a fellow of Royal College of Obstetrics and Gynecology. Welcome very much, our panelists, for this conversation. We'll just supply you with microphones so that we start this conversation. We'll take the first round of questions, and then Professor Ame will take the second round of questions. Then we'll welcome the second set of discussants for this conversation. I think handheld microphones. Is mine okay? My microphone, I think, is okay so that we can share this one. Are we okay with the sounds? We can go ahead. We ready? Sound team, we are okay to go? Okay, so we'll take our first question, and I'd like to throw this to Dr. Bashir, just to give us a brief on how the program has contributed to the national MNH program strategies.
Thank you, Mercy. Good morning, everybody.
Good morning.
My name is Dr. Bashir Isaac. I head the Department of Family Health, where reproductive maternal health is one of the divisions. The rest are nutrition, child and neonatal and child health, adolescent and school health. Having been in this journey with Make It Happen from 2012, actually 2010 when we started designing this program with FCDO. By then they were called DFID. So we've walked this journey with Dr. Ame, and we're happy now, 10 years or more down the line, we're celebrating the design of at that time. Then things were very different, although still we're not out of the woods in terms of the numbers we're reporting, but much improvement have been achieved by both the government of Kenya, whose contribution cannot be priced, and Make It Happen as a program. We started with, they started with the training of provincial headquarters, just at the provincial referral hospitals at that time. But when they came to my office, when I said, well, how far, when are we going to reach the health facilities? Because what we're dealing with is last minute rush. And how many will not reach these level 5, level 6 facilities, level 5 facilities then? The second phase was this one now, which is Make It Happen. And going to the in-service, pre-service training was also a design, because it is not tenable. The costs, we don't have the resources. The partners are not going to be with us forever. And the cost of in-residential training is not sustainable by any country. So all these innovative ways of doing business and achieving much more impact is something we will thank LSTM and the team, their sponsors, FCDO. As a country, we have achieved a lot, but it's not time to walk away. If you look at the statistics that have been shared, 355 maternal deaths per 100,000 is not acceptable for this country, because we have the resources, whether it is human, system, government, or financial. The government has put in this, after this design is when we also thought about the free maternity services, which is quite a huge investment. 5 billion shillings annually, ring-fenced for free delivery. I think many of the African countries are still struggling to emulate us. The issue of knowledge sharing, which happened in the counties and also happened in LSTM itself in Manchester. Unfortunately, I was not able to participate, but we've sent teams. The MPDSR, maternal perinatal death surveillance and response, is also an idea that was started by this program. It's an idea that we are unlikely to work out. It's an idea that has not reached its 100% potential, but at least we can know every mother that dies in our facilities or in our community is being audited today. We are proud to say that. The skilled birth attendants have increased from 40-something at that time to now 85, 86 there as a nation. Our skilled birth attendants have not translated into reduced maternal mortality because the numbers are still the same. The KDHS this year has not included maternal mortality statistics because we just had the 2019 statistics of the census, and therefore we come to the point now, what is the issue? We have put resources, we have trained our people, whether it is in-service or pre-service. We have provided free maternity services. Our facilities have increased. Devolution was a big blessing for this nation, especially for health. I will say that, and I'll repeat it every time. What is the issue? The issue there is now the quality of care. the quality of care, which is the responsibility of every health worker and every community member. If we address that, the world is now thinking in terms of why is maternal mortality in sub-Saharan Africa not coming down as much as it has come down in other parts of the world? There are some countries whose maternal mortality per 100,000 is 5, 4. These are countries that 30, 40 years ago were at the same developmental level with us. They were sharing the same statistical status with us. So our focus right now as a ministry is to focus on the quality of care, and that is where we want our journey to be moving in that direction. Thank you very much.
Thank you very much, Dr. Bashir, for that. I think next, let's hear from the counties. And you said skilled birth attendants have significantly improved in the country. Vihiga County is at 95%. So, Governor, what are the sustainability and scale-up plans for better outcomes in maternal and newborn health? And at least you've had the advantage of having been in the county since inception. So how can we scale up?
Thank you. First, I want to take this opportunity to thank the organizers of this meeting for inviting me to come over. Second, I want to say, as a county, we are very, very grateful to this program. And this program, for the last 4 years, has been in operation, has made a major, significant improvement in our maternal and newborn care in the county. And we have seen significant changes in improvement. We have seen maternal mortality reduced from 119 per 100,000 to 22 per 100,000, which is quite a significant improvement. We have seen improvement in skilled delivery, moving from 55% to 86%, which I think is quite impressive. So in a nutshell, I would say we are very happy with the program, and the impact the program has had in our county is going to have a lasting imprint in our healthcare system. I want now to come back to your question: how do we maintain sustainability of this program? First and foremost, we need to have leadership support of the leadership and conviction of the leadership that this program is good and it's the way to go is very important. So leadership must impress the program. Second, we need to have legal framework, because without a legal framework, it's not easy to incorporate the program in the normal funding mechanism of the counties. So legal frameworks are very important, both the policy and the law. And I'm happy that for us in Vihiga, we have been able to put the policy in place. We have been able to put the legal framework, that's the bill, in place. So that gives us a leeway to be able to put this program as an ongoing program within our programs. And therefore, that guarantees sustainability. And second, we, through this program, we have learned and we have had a lot of support in capacity building. And our experience shows that taking this program to the grassroots, to the village level, has more impact than having it at the county level or at a higher level. So we have invested a lot in our community health volunteers and community health assistants to ensure that this program is mainstreamed at the local level. And at that local level, through this program, more emphasis has been placed on hands-on practice, having little theory, but having a lot in terms of practice and sharing information from various sources. And this gives us a higher leverage on how to move forward. So in a nutshell, I would say we are happy with the program. We have put the legal framework in place, and our motto is that wherever we get various partners, we want to co-fund the program. And not only this, any other programs in our county. We do not want to have just direct funding. We want co-funding and co-implementing. Thank you.
Thank you. Thank you very much, Governor. From the grassroots impact that you've mentioned through community health volunteers or community health workers is taking theory to practice. But before they come to practice, they are learning theory somewhere through the pre-service training, which is quite important. And so I'd like to ask Professor Cheserem how the program has impacted the capacity for quality M&H services from the pre-service point of view.
Thank you very much. As the training institution, we've actually had a relationship with the LSTM since 2009, and we have been having training of our registrars, that's the students who are in the MED program in IMOC, to the point that we have trainers of trainers within our institution, and we have mainstreamed that. And we've gone further to put it in the curriculum to make it sustainable. Currently, the latest one which we were doing with them was advanced obstetric skills and anesthetic care, which amazingly, we've managed to train all our registrars. They are 4 years, year 1 to year 4. And we have managed in that collaboration to have trainers of trainers within our own registrars, and we are going to upscale it in the sense that we want to be the owner, to take the ownership. And if we can have a partnership even with the counties, we will then be training for the counties, maybe the staff who have not been trained. But just to come down to our college or our faculty, we are concentrating on having it being sustainable by having our own trainers of trainers, doing continuous seminars among themselves. The only people who have not been trained on this latest skill are the students who joined us in September for the program, but we are planning to do that for them. So for us, we are on it, and our research, the latest research output from the department, let me talk of my department because that's where the reproductive health issues are discussed and carried forward. Our research is quite vibrant, and we do meetings twice a week to make sure students progress as they come in. They must have a marked proposal concept by year 1. By year 2, they must be collecting data. By year 3, they must be doing analysis. These are implementation research. And we do a lot of collaboration. By the time they reach 4th year, they should have done away with the proposal. It should have been converted into a thesis. And the last year is to concentrate in improving the skills. I think I'll add more in the next 2 questions. Otherwise, I think we are doing our best. Our students have done much. As far as improving this at the point of care, we also have a review of maternal perinatal death surveillance every month, which is very intense, and that gives us lessons to learn on how we can improve what we have not been able to achieve. It is a learning curve for us. It's not punitive, so we don't punish anybody, but we want people, all of us, from the senior to the lowest, to learn from what we can improve in our setup. Thank you.
Thank you very much, Paul. And in there, I'd like to reiterate the fact that this program led to the review of the curriculum and syllabus at the KMTC's training, which is really significant in terms of sustainability in the long run. My next question to Akacho from FCDO. We have less than 8 years actually to the end of the SDGs. So how do we utilize the evidence generated from this program to ensure that Kenya is in line towards achieving the national MNH targets?
Thank you. Thank you. And first, I'd like to say thank you to the government of Kenya through the Ministry of Health and Council of Governors. And we also do appreciate the support we get from the counties, and also to our host, LSTM, for hosting us today. So as most of you know, Kenya has been an instrumental country in terms of the commitments we have made towards the Sustainable Development Goals. And as much as we have discussed the data today in terms of improvements in skilled birth attendance and antenatal coverage, there's still much more to be done with respect to getting to our targets. We know we are at 355 for MMR, and we're hoping that can go down to even below 80. But what do we need for this to happen? And in line with your question, this cannot only be an effort of what the donors do. It has to be a concerted effort. And thank you to Governor for also mentioning that we also do have commitments from the counties. And this has also been part of the work that we have been doing to support domestic resource mobilization. And we know that Kenya has also committed to the ICPD 25 commitments, which are to have 0 preventable maternal deaths by 2030. We've also committed towards 0 violence or harmful practices against girls and women by 2030. And we also have committed to 0 unmet need for family planning by 2030. So you can see there's a very big task ahead of us. And we have been reminded we actually have 7 years left to achieve that. So what do we need to do? So sitting from the donor perspective, what we have been doing is also using evidence-based decision-making for our programs. And as you can see, there are quite wide disparities across Kenya. The latest demographic health survey showed the indicators are not only bad in the ASAL regions, but we're also starting to see bad indicators across Eastern region and even some pockets of Central Kenya. And you can see that health is cutting across every part of our sector. Today, drought was mentioned. We cannot not talk about health without the drought. So as you can see, it's not just the mothers not getting access to the services, but if they're not able to feed themselves, they're not able to feed their children, they're not able to feed their families. How do we come together and do integrated programming where we're not just relying on parallel programs, but also integrating by strengthening the nutrition aspects, as well as looking at other development indicators as a whole. Professor has also just given very good statistics here in the morning. And we can see that as much as we've scaled up on the in-service, the pre-service is also particularly important as we see the number of nurses that we're generating annually, as well as the clinical officers and the other health workers. We are also looking at ways of strengthening innovations, and that is particularly important as we see the most vulnerable communities that are yet to be reached in Kenya. And these are not just only for women and babies, but we're also looking at persons with disabilities, as well as other communities that are not close to health centers or close to areas that have service provisions. Governor has also mentioned building up on level 1, which is the community service delivery. And we're also working closely to see how to scale up investments and strengthen the support of the community health workers. And then, of course, I cannot finish without talking about equity and ensuring that we're having equitable distribution of resources across the counties and also across national. Thank you.
Thank you. Thank you very much, Akacho. Then last but not least is just ask Lucy, the LSTM country director, if you're given this program over the next 4 years, what are the pitfalls you would avoid in running the program again?
Thank you, Dr. Mercy, and thank you everyone for being here. And I think that's an interesting question because this is being asked to look in hindsight, but I think hindsight helps. And I think part of it has been covered when Professor Hame has been speaking this morning, but I'll try again to just re-emphasize because I think this is the purpose of this event, learning event. And therefore, since it's not a reality that I'll implement it in the next 4 years, then it's for us to really pick up those that are going to implement, those that are going to fund. And I'll start with the first aspect. I think the very first aspect that I would think of is coordination. I'm thinking this because, I'm a manager and I look at those things that, trickle down that affect everything, that affect, the output, the technical bits, the relational aspects. And in terms of coordination, I have 3 key aspects to look at. First is coordination between, donor and government. And I think it was alluded to in the morning where we have, I think as LSTM, we have felt sometimes put in the middle and tossed around, especially when it comes to, agreeing on allowances and per diems. And one partner, one key stakeholder we are supposed to please, in quote, says our policy says this, the other policy says this, and here go deliver to us 1,000 women, and yet we are supposed to coordinate that. So I think that's one of the things that I would look at if I were to design such a program. Such things really need to be very clear. But I'm also happy, as I look at these pitfalls, I think we are not where we began. Because when you look at this aspect, for example, donor-government relation, there's a time that came as LSTM and we stood up and said, now this is not our issue as LSTM. Can you two discuss and please give us? And I think it has gone away ahead to that high level, such there's that bilateral discussions in terms of MOUs and aspect that needs to be considered. Although, of course, it's just not about per diems and things like that, but then it touches on, how do we coordinate such that the thing that we want to achieve really as some kind of focus. Then the other aspect that I would like to look at also in terms of coordination is also the aspects in terms of operationalization between the national government and the county governments. We are implementing these together. National government making policies, the county governments, doing the implementation aspects. But we find sometimes there isn't complete. There's something in writing, but there's not either complete agreement or there's not clarity in terms of how do we coordinate this at national level and at county level. And sometimes we found that we are going to train or we are going to do an intervention, yet we have a bit of either absence or aspects like that. So that kind of coordination, I think, helps a lot, not only for LSTM, but I think for all partners who are going to design such programs. If these key aspects are not looked at, we really lose a lot of time and efficiencies, which, in other words, we should be translating into actual aspects. And the third part is partner to partner. When leadership is not there, I think it becomes quite challenging. I'll give a specific example. I know we've been training in counties, and what has happened is that we find that we all want to do mentorship in EMOC training, for example. I'll give this as a very vivid example. And we go to a county, one partner is funded by donor A, and we are funded by donor B, and we all are, mentorship is proven way of improving outcomes. But one approaches this, the other partner approaches this, and you find there are all those intricacies. We are targeting one healthcare worker in a county to do mentorship, and you find that there's conflict between the partners themselves, but also the healthcare worker is left in the middle, and the partner, some of the time the partner is left, stranded. You have planned an activity, no one appears. But I think those kind of coordination aspects really need to be looked at from the beginning of the program, because it's not I mean, we are all heading to one thing. If we do not coordinate this, it's okay. I mean, it doesn't seem okay. But I think for the pitfalls also, we are not, as I'm saying, we are not where we are. Because if you look, for example, at now the mentorship aspect, we have national guidelines that have been developed. So I think that's a sorted issue. But it really ate a lot of time, efficiencies, and I think what would have been achieved earlier. So that's one. The second thing that I would really want to speak about very quickly, Mercy, is about funding. And in two ways. Funding this program, I think we all know about 2020 and the impact of COVID. There was funding cut, especially on the FCDO UK aid budgets. And I think it was a survival means for everybody. Everyone had to tighten their belts. And you know, what we planned 10 years ago, we had to really scale it down, and it was inevitable. But no one in our wildest dream ever thought that the world would face such a crisis, and yet the health systems were not prepared. No one was really prepared. Governments, partners, donors, they were all not prepared. So I think this is a key lesson learned. We don't know what comes next, God forbid, but I think putting contingencies in place, you know, for those unforeseen things, such that when such things shake the world, people are still giving birth, whether COVID or not, or whatever else comes or not. So those contingencies, I know traditionally for those who have been in the field with us, developing proposals, we have almost a very lax, you know, risk matrix. And there are things that we always put, you know, those normal things, we anticipate these, we put this in place. But things like COVID have exposed the health system really, really badly. I think it has been the most affected one. So for the next partners or for ourselves when we are designing these programs, I think such contingencies from partner, government, and even, you know, stakeholders just need to put that in place. And finally, Mercy, in terms of funding also relatedly, is because this program was designed to be heavily donor dependent. And I mean, we've talked about per diems, we've talked about if things need to be done, it's like that. I mean, it has to depend on those funds. But happily, I think we've had His Excellency speak about funding. Before we got there, let me tell you, as LSTM, we called it indirect training, where LSTM was to put in some money and the counties would put some money. Counties are very willing. Even the national level is very willing, but it's not as simple as that. We know about funds flow issues. And if we may commit here, but if that is not addressed, you know, that will not happen. But even the aspect of even other donors as they continue to fund, if the program is not designed from the beginning to take into consideration. I've seen where we have other donors or even the Global Fund sometimes where you say one-to-one. You know, you put this, we put this. If that is inbuilt into the program from the beginning, it helps. Thank you, and back to you, Dr. Mercy.
Thank you very much, Lucy, for summarizing that on coordination, preparedness, and the issue of funding. And from the panel, obviously, partnerships are very key in making sure any program is successful and also bringing us together to actually just have this conversation on lessons learned. So on the next steps from each of the panelists, I'll hand over to Professor Ame to take over that set of questions and also just give us his ideas of what the next steps are.
Yes, thank you very much, Doc. So I think that, so at the start of my talk, I said, you know, one thing we can do going forward. So we have a few years to the end of the SDG. And if we know that there are specific parts of the country that contribute the most to maternal death, or where there's the risk of maternal death is higher than other places. Over a couple of years working in Kenya, we know what works. We understand the context. Improving maternal health, reducing maternal mortality is not a simple thing. It requires multiple interventions applied, you know, at the right time to bring about a difference. Unlike, say, preventing malaria, you know, some mosquito nets, some chemoprophylaxis, you'll be all right. But with maternal health, it's a bit complicated. From financial access to facilities being prepared and ready, you know, to respond. You know, women having enough good quality prenatal care and all of that. So you need multiple interventions. So I think for me, going forward, we know what works. we will need to put a bundle of interventions focused on these problem areas over the next few years. So it's a tactical thing. I'm not saying in other places you should take your foot off the gas, but put something in place to have things going, to maintain them, but you need concentrated efforts in certain areas. That will rapidly bring down the national average. So for me, if that opportunity was there, I think me and my team will be, in pole position to take on that challenge. I'll pass on to other colleagues for their reflection on this issue, on the next step. Maybe I'll start with Dr. Bashir.
Thank you, Charles. You have taken my point, actually. Yeah, if we don't address inequity, we are just burying our head in the sand. Statistics don't lie. The last KDHS has given us glaring statistics on the disparities within the country. And those are the statistics that are giving us 355. Because you have counties that have 98% coverage for maternal skilled birth attendant, with very low, even below our SDG targets within this country. And there are counties that have 6 times, or I don't know, several hundred times within the same country. As governments and as donors, we have to bite the bullet. And the bullet is, can we identify the target areas that are contributing to a high maternal mortalities? That's number one. We have to deal with inequities. The inequities are not only in health, not only in maternal health. As Charles said, dealing with maternal health is not a walk in the park. It is dependent on the social determinants of health. The level of education, the availability of water, the multi-sectoral approach, even within these target areas, and heavy investments. UNFPA program tried one time. We did some analysis, and we found out that there were 15 counties that had high maternal mortality. Out of that, 6 of them were contributing to over 50% of the maternal mortality. Unfortunately, that program was good, but it was a very short. You cannot turn around maternal mortality in 2 years. So from the beginning, the design was faulty, and the sustainability issue, which we are discussing here now, needs to be imbibed in any program that is futuristic. Secondly, the opportunity that we have is the county governments have resources, and here, His Excellency has already said that they are putting resources. And those counties also have identified maternal mortality and maternal and child health as their flagship projects, which means they are also willing to put in resources. Even if it is 50-50, it's a matter of we can discuss with the governors and the Council of Governors. And in the next 5 years, we can be talking about other statistics. Fortunately, the ASAL region is not that populated. So the numbers can really come down if we really have the right innovative strategic interventions that we have. We know what works. The high impact interventions are there, although of course there are some other brainstorming issues that are coming up, redesigning maternal and child health to bring down the mortalities. But for us, the signal functions that we've been working with has been found to work. And that's the opportunity that we have. Deal with inequity, use the evidence that you have and the statistics that you have, and also partner with the community and the county governments together with the national government. Thank you.
Thanks a lot. Let me go to you, a colleague from FCDO. So I know you probably have other existing programs now. How do you see complementarity of programs, to help support this accelerated reduction in maternal mortality?
Yes, thank you, Prof. And I'll just like to echo what Dr. Bashir said about the burden of maternal mortality in Kenya. And the UK is currently the largest donor in family planning. And family planning is a best buy to avert maternal deaths. And so we were happy to see with the recent demographic health survey a direct correlation between the counties we're investing in and also reductions in some of the burdens. So for example, unmet family need for family planning, as well as also improvements in stillbirth attendance and other maternal mortality indicators. However, as has been mentioned, we only work in 12 out of 47 counties in Kenya. And to touch on to Lucy's point, it cannot just be one donor who comes in and fixes the system. And we do appreciate the efforts of the government of Kenya. For example, with this program on maternal health, we have had heavy investments in terms of providing the facilities for training. The equipment has also been picked up by the counties and also the health facilities. And also we cannot forget the investment in human resource, as we can see by the experts on this table. However, we are now 10 years post-devolution, and our indicators are not doing as well as we had projected. Of course, we do not deny the impact of COVID. However, I think the call for donors has been, given that we are now at low middle income country status, Kenya should be able to put in more investments in terms of resources for the health programs. And we can actually see increase in investments at the county level. Most of the counties we are supporting have a minimum of 30% of their budget going towards health. However, as the programs have shown, 70% of that budget is for human resource and administration. So the donors are calling for more investments in terms of implementing towards service delivery. And as this program has shown, we need much more higher investments to build onto the packages because the packages work. And we also need to invest on the research and robust measurement of MND. Yeah, thank you.
Thank you, can I pass back to the MC? I think the panel in various responses have really reflected on how things can, how they see things going forward. I mean, there may be other partners in the room you may need to call on, to give their view. They're key donors or stakeholders in reproductive health who may have some ideas to contribute to this conversation. Thank you.
Thank you, Prof. We'll be welcoming the donors immediately after this just to give their input. I'd like to just ask Governor first, is there an opportunity to replicate the approaches and some of the things that have been done in Vihiga in other counties as part of next steps, so that it's across 47 counties and not just 1, 2, or 5 of them? Governor.
Thank you for that question. Yes, it is possible to replicate what we are doing in Vihiga in the rest of the 46 counties. As I said from the onset, is commitment by the leadership. That is the starting point. The leadership in the county must put a priority on maternal health care. Then that becomes a priority. Second, you need a legal framework, because in a government system, without a legal framework, you cannot spend money, whether you receive it from Treasury or whether you collect it yourself. So that is something that can be done. And I'm happy to report that we at the Council of Governors, we have taken this matter very seriously, as you heard from the speaker from the Council of Governors. And I am in the Committee of Health, and just a month or so, we engaged the ministry discussing this issue and other issues relating to universal health coverage. And we have agreed with the ministry that we need to work together to be able to achieve what we want to achieve. And one of the areas where we have agreed to work together is the issue of community health volunteers, the first line of defense in our healthcare system. The ministry has agreed to work together with the county governments to find a way to put CHVs in a sort of a full-time engagement where we give them some stipend to be able to engage them. And I think that is something I would say we are very happy with the ministry for having agreed to do that. Mm-hmm. So in the next 3 years, we will be working with the ministry to build the CHVs at the grassroots level. Okay. We have agreed as Council of Governors through the Committee of Health that in our current CIDPs, we are currently preparing CIDPs for the next 5 years. We have agreed that the issue of maternal and newborn healthcare system must be inbuilt in the CIDPs so that we can be able to fund it, and we can also get partners who can partner with us and move on. Mm-hmm. So yes, I want to assure you that yes, as a Council of Governors, it is possible, but as I said earlier, it's also goodwill from the leadership. For example, for us, we made a decision that we will move forward and support this program, and we have gone much higher than the rest. We decided that it's not only just giving stipend to the community health workers, but it's building capacity. And this program has helped us to build the capacity, but it's also giving them basic requirements to make them feel that they are doing their work well. Mm-hmm. Equally, the mothers during pregnancy, we have found out that yes, you can do the rest, but the issue of nutrition is very crucial during pregnancy. Mm-hmm. So again, we have come up with a program, and we are among the first counties who have come up with a nutrition policy so that we can incorporate this into the program on maternal and newborn program. Mm-hmm. So there are many things that we want to look into, mm-hmm. and that is possible. And I want to say that we are working together at the Council of Governors, and this is possible.
Mm-hmm. Thank you very much, Governor. I'd like to adjust our program just slightly while we have the panelists here to field questions from the members of the Fourth Estate, the media that is represented here. If anyone has any question for our panelists, this is your opportunity to. Media, before we let the panelists take their seats, anyone with a question? Anyone with a question from my colleagues from media? I'll take it that the information that has been provided has been sufficient. So I'll give Prof. Cheserem the last say on the next steps in scaling up the program from a training perspective.
Thank you very much. This came at an opportune time for us because we were just going through our university reforms. So we've managed to actually include what we didn't have in the curriculum, and we are going to upscale it and mainstream it. In terms of the training of all that we have mentioned, as far as our research, which is operational, we are working very hard to do publications continuously. We have several outlets, but we want to really look at the journals which are quite outstanding for our spread of our evidence. And we are championing in the university now the training of manuscript writing. It started in our department, but now we've given it to the faculty. We are training our registrars and even our staff on manuscript writing so that anything we do gets to the public domain. As we absorb it, other colleagues in the same profession can also use it. We are strengthening our mentorship as part of our reforms. We realize that because we have had issues of we have not been employing new lecturers and all that. So we cannot force it when there are no funds. So we've come up with a way of getting other specialties who can add value to our department. And we've appointed quite a number of honorary lecturers and also adjunct faculty from anywhere in the world and even from locally, those who qualify to come and help us. I'm proud to announce that Professor Ame is part of our faculty, and he comes often to do training. He's just been doing continuously with us, and right now he will take a bigger role of mentorship, whereby he will even supervise MED research, and he will be participating in our meetings, the ones we do twice a week, to make sure that we beef up research in our institution. We have had challenges in terms of sponsorship for our registrars. We take about 35 to 40 every year to do MED in Ops Gynae, but the challenge is sponsorship. So I'm happy to have an eminent governor here who will know that we need them to really sponsor the doctors who want to come and do different programs, because that's where your capacity will be sustainable. University have come up with other innovations in terms of work study for the students, so we give opportunity to our students who apply for that so that they can get money to supplement their school fees and also for their utility. That helps to retain them, because quite a number may come and just apply for to suspend their program, which affects us negatively. There's also University Foundation, which was started last year, and we keep on giving, the university gives scholarships to very needy students. In my department, I have in every class about 2 of them, which is quite commendable. Don't forget that they don't exit at the same time, so it's accumulation of quite a number of them who get these scholarships. So MOH also is our funder, so they have quite a number of those who are sponsored. That is part of our plans to make sure we strengthen our training and also get these things to be mainstreamed in terms of way forward. There are programs which we used to do, as you know, maternal health and perinatal health, as other factors which affect it, like nutrition has come up, but we know that the nutrition of the neonate is very, very important. It was just last week when a neonatologist told me, I've realized that some of the students have not, some of the staff do not know how to deal with breastfeeding issues. We have had this program for many years. I'm a trained person in this, even advanced. I went to San Diego for further training, and it helps. So we are going to restart and invigorate that training so that every mother who is in our ward can be trained on the proper methods of breastfeeding, because it's not a natural skill which comes automatically with motherhood. So we are trying to look at other areas which affect maternal mortality and perinatal mortality in total and scale it up. Okay. As far as what I've said in terms of what we are offering, we are all going to mainstream this. The way we did EMOC, we are going to do this for the other training on advanced obstetric skills and anesthesia, so that we own the process. And as we do that, we are going to send out people who are all-rounded. We are seeing from just the training which has taken place that the skills of even assisted vaginal delivery has gone up. And within a very short time of training, we reduced the number of cesarean sections, because our registrars were able to intervene at that level. So we are doing all that we could to make sure point of care is improved. And maybe I can touch on partnerships. It's okay.
Okay. We'll
we are
pick
doing
that
other
up in
things
the
also, like point of care, ultrasound.
We'll pick that up in the subsequent sessions and meetings during the day.
Thank you.
Thank you very much, Professor. Sorry for cutting you short, but we are running out of time. Let's give a round of applause to our panelists and for sharing the information. We can release them to take their seats. You can now take your seats. Our panelists have been Akacho Ekirapa from FCDO, His Excellency Dr. Wilbur Otichilo, Governor from Vihiga County, Dr. Bashir Isaac, the Head of Department Family Health at the Ministry of Health, Lucy Nyaga, who is the LSTM Country Director, Professor Eunice Cheserem from the University of Nairobi, Department of Obstetrics and Gynecology, and last but not least, Dr. Ame from LSTM. Thank you very much, ladies and gentlemen, for your insights and inputs into this conversation. So we'll go to our final bit before we take our health break, where we'll get remarks from Dr. Chris Oyeipo, the Deputy Representative of UNFPA. I'll give you just 3 minutes to make your remarks, then we'll welcome Dr. Muller from the Ministry of Health. Let me give you a microphone.
I've been given only 3 minutes, so I'm going to do everything within my power to stay within that limit. His Excellency, the Governor of Vihiga, Honorable Wilbur Otichilo, and permit me to, after this, just stand on the already existing REACH protocols and just say, distinguished ladies and gentlemen. I bring you warm greetings from the UNFPA representative, Mr. Anders Thompson, and from UNFPA. For us, being here today is a must. This is a great partnership, a partnership that is key to the 3 transformative resources which UNFPA is pursuing. As we all know, Kenya has indeed made good progress in reducing maternal mortality and to improve maternal health indicators over the last decade. But as has been well said here today, we still have a lot to be done. And in this regard, UNFPA acknowledges the collaboration and partnership with LSTM, especially in terms of producing the first confidential inquiry reporting to maternal death, but in all other ways. And we also appreciate the funding from the UK government in several of our activities. It is possible, as we have said today, that, and as has been ably said by the panel, that the high access to skilled care has unfortunately not yet resulted in concomitant reduction in maternal and perinatal deaths. This, we have all agreed, is due to issues related to quality of care. Therefore, as UNFPA, we are committed to strengthen the capacities of counties